I'm going to talk today a little bit about cancer disparities. The title of the talk, of course, is Cancer Doesn't Discriminate, or Does It? And, you might ask, kind of given my research interest, why this topic? The pandemic has allowed all of us to become, as Jason Puckett said earlier today, we've all become kind of technology experts on giving virtual presentations. But I had the privilege of participating in a webinar that was kind of co-sponsored by the Cancer Center as well as Gilda's Club and the Kentucky Cancer Program on cancer, racism, and clinical trials. And my piece of that was just talking about diversity in clinical trials, or lack thereof, to be honest. And we had really just a riveting discussion with a patient panel, and it just really piqued my interest in disparities in cancer treatment in general and what we can do to try to improve that. And so this talk is really kind of sort of stemmed from that. And so hopefully this will pique kind of the same interest for you all. Okay, so conflicts, my only conflicts are really institutional support as a PI of clinical trials. A disclosure, if you will, is I am not an outcomes researcher. So this is me kind of putting on sort of a different hat, not one that I typically wear, to kind of mine through some of this data to talk a little bit about, diversity in cancer as well as clinical trials. So the objectives to review racial and ethnic differences in cancer incidence and outcomes, to explore initiatives to address cancer disparities, and then to really examine the role of clinical trials in challenging that status quo. Okay, so for those of you who haven't already kind of heard this is sort of a depiction of what I would consider Kentucky's cancer crisis. So these are numbers from a couple of years ago now, the most recent numbers available, and this is, all published online at cancer.gov. So this is cancer incidence and mortality. The blue bars are in the United States. So new cancer cases, about 450 per 100,000 people in the United States. In Kentucky, that's about 520 per 100,000 people. So in short, if you live in Kentucky, you are about 16% more likely to be diagnosed with cancer than the average person in the United States. In Jefferson County, those numbers are even slightly higher. What's more concerning is the cancer death rate. So not only are you more likely to be diagnosed with cancer if you live in Kentucky, but you're more likely to die of cancer if you live in Kentucky. So the cancer death rate in Kentucky is about 22% higher than it is in the rest of the United States. And you can see the Jefferson County numbers are similar. So this is what I call our cancer crisis, all of us. This is kind of breaking down the U.S. cancer incidence and mortality by race and ethnicity. So if you go to the left, the new cancer cases, you can see that actually patients who identify as white are more likely to be diagnosed with cancer. That number is a little bit higher than 450, around 460 or so per 100,000 people. So the majority of new cancer cases in the United States happen in a white population. However, where the disparity is when you look at the cancer death rate. You can see those bars change a bit, and patients who identify as Black or African American are more likely to die from their cancer. If there's any glimmer of good news here in Kentucky, the racial disparities are a little bit less so in Kentucky, which is somewhat encouraging. So as I mentioned earlier, in Kentucky, every year, about 1 out of 200 people are diagnosed with cancer. In the white population, that is 1 in 192. In the Black population, that's 1 in 208. So similar, but again, kind of mirror the United States in that white patients are more likely to be diagnosed with cancer. African American or Black patients are still more likely to die of their cancer in Kentucky, but the difference is less pronounced than it is in the rest of the United States. So about 1 out of 3 patients will ultimately die with cancer will ultimately die of their cancer. In Kentucky, those numbers for the white population are about 37% of people of white patients with cancer will ultimately die of their disease, and for patients who are Black, that is about 39% of Black patients will ultimately die of their cancer. So the numbers, again, there's still disparity here in Kentucky without a doubt, but a little bit less pronounced than in the rest of the United States. Okay, so this is just a sampling of the facts, just to kind of get the point across that this really is a problem, and we'll dive into these a little bit more. So Black men are twice as likely as white men to die of prostate cancer. That, to me, was pretty profound. Black women die of breast cancer more often than white women, despite a similar likelihood of being diagnosed with the disease. So again, when you look at risk factors for things like breast cancer, when we look at insulin resistance, obesity, et cetera, it's not just all about the diagnosis and kind of initiation of cancer, but rather something about race and ethnicity make someone more or less likely to respond to treatment. The highest incidence in cancer death rates in colorectal and pancreatic cancer, which are some of the more lethal cancers, are in African Americans or Blacks. And again, non-white patients are nearly twice as likely to be diagnosed or die from gastric cancer. So there are clearly disparities. And, to be honest, there's not going to be one thing that causes all of this. There are multiple reasons for all of these. So access to care is a big one. So despite, the Affordable Care Act, which has been in existence now for, a little over 10 years, there are still a fair amount of uninsured Americans. And unfortunately, disproportionately, those are minorities. The lack of insurance means you don't see doctors and providers. It's expensive to get to the doctor, right? So, if I don't have insurance, I can probably work with the folks over at the hospital to try to come up with some kind of payment plan. But if I don't have $50 to put gas in my car, there's no tab for the gas station attendant to say, okay, don't worry about it, pay me next time, right? So if I can't put gas in my car to get to my doctor's appointment, I'm not going to go there. And then even those with insurance, I think we underestimate the cost of cancer care. It's not just a problem for the uninsured. In fact, maybe it's more a problem for those with insurance, especially those who are underinsured or have poor insurance. Cost of cancer care is rising precipitously. Part of that is people are living longer, which is a really great thing. Part of it is what I kind of consider what I call boutique medicine in cancer care. And what I mean by that is not that you get a fancy cancer center with a spa, but rather that we have become so personalized or genetic-minded, molecular alteration-minded in the treatment of cancer, that a lot of drug development is happening in small niche patient populations. So there will be trials that are open for a patient with XYZ alteration that may be present in about 4% of cancer patients, right? So increasingly, drugs are being approved and marketed for a very small niche population. What that means is those drugs come with astronomical price tags because that company somehow has to recoup all the money they spent on R&D, and yet it's only applicable to a very small number of patients, which means each dose costs, ridiculous amounts of money. And so cancer care is going up not only for insurance companies, but also patients who pay copays and deductibles, and there really are max benefits. At some point in time, you exhaust your insurance benefits. So cost is a big problem, and when you can't afford to go to the doctor, it results in late diagnoses. So patients diagnosed with later stage disease, they aren't being screened. They present later from cancers that have been neglected because of lack of care. And then even once they do make it to a doctor and are diagnosed, inadequate treatment, whether it's because of the inability to make it to the doctor, whether it's because perhaps a suboptimal treatment regimen is chosen simply to decrease the travel burden or decrease the intensity of monitoring that's required. So there are a lot of factors that play into kind of access to care that result in disparities in cancer. And unfortunately, a lot of those issues are more prevalent in minority populations. Environmental exposures, so things like diet. There's a lot of research going on now about what we put in our bodies and how that affects cancer. And not only how it affects cancer incidence rates, but how it affects our responses to treatment, and in particular with respect to immunotherapy, and how our own immune systems react to cancer based on what we expose our body to. That can be food we eat, that can be a lack of certain nutritional components. There are a lot of things that factor into that. Infectious agents, so viruses in particular, things like viral hepatitis, for example, when it comes to risk of liver cancer. And then pollution, air pollution, and in Kentucky, you have to think about things like radon as well. So radon is increasingly recognized, certainly as a cause of lung cancer, but now even breast cancer and other things. And so folks who live in poorer neighborhoods perhaps don't have access to things like radon mitigation systems or even monitoring. And so things like that are really important to consider when we think about why cancer incidences might be higher in certain populations. And then lastly, of course, genetic predispositions. So we are all a sort of mix of our ancestors, right? And that comes with a lot of different genetic differences, let's put it that way. And so people who are more or less likely prone to cancer based on their genetic makeup. And that's something that I think is increasingly recognized and has been honestly now for a couple of decades. But part of the problem is that a lot of this research has happened in white populations. And so there is less data out there about minority populations and how specific alterations may affect their risk of cancer. Okay, so prostate cancer. So as you can see in the picture at the top, prostate cancer is about at least a little over 1.5 times more likely to occur in a Black man as compared to a white man. In addition, Black men are diagnosed with prostate cancer at a much younger age with more aggressive disease and are more than twice as likely to die of their cancer. So there is something, probably more than one thing contributing to that needs to be teased out further. When we talk about genetics, there have been some susceptibility loci identified that perhaps put certain populations at a little bit greater risk that seem to be more prevalent, or alterations in those loci seem to be more prevalent in African American populations. There are lower screening rates, and we can get into a whole conversation about, screening and prostate cancer. But the fact of the matter is African American Black men are screened for prostate cancer at lower rates than white men, despite worse outcomes. And then finally, racial and ethnic minorities reported worse quality of life following treatment for prostate cancer. So things like urinary incontinence, sexual dysfunction. And so if you are a man and you're diagnosed with prostate cancer and you're talking with a surgeon or a radiation oncologist about what are your treatment options, your kind of knee-jerk reaction is, let's ask around. Who else has had this? What are your side effects? And so if you're asking family and friends who are reporting much worse quality of life and complications with respect to treatment, you may think twice about undergoing what is considered appropriate cancer treatment. So this was kind of an interesting study to me. So this was a study that looked at all clinical trials for prostate cancer between 1987 and 2016. And they selected those that had available racial demographic data, which was actually a minority of those studies that actually had demographic data available. When you look at the studies that had demographic data available, more than 96% of the participants in those studies were non-Hispanic white men. So we just talked about how non-white patients, in particular Black patients, have much higher incidence as well as mortality from prostate cancer, and yet in clinical trials, greater than 96% of participants were white. That number, that 96%, is heavily dependent on screening trials. So when you look at those 59 trials that they looked at, only a handful were screening trials, but those screening trials are huge trials enrolling hundreds of thousands of men. So the screening trials themselves made up 700 and some thousand men. But when you look at the screening trials, you can see that pie chart on the left. The blue is white men. In screening trials, 97.5% of participants in screening trials were white men. The middle pie graph is the new cancer, so cancer incidence in general. 75% of prostate cancer happens in white men. Even though it's more common in Black men, it's when you look at the population, the actual raw numbers, the absolute number of cases diagnosed every year, 75% are in white men. But when 97.5% of screening trials happen in white men, you have to ask yourself, when you're having a conversation with a Black man in front of you about the utility of PSA screening for prostate cancer, you have to ask yourself, does everything I've been taught about PSA screening and shared decision making, does it apply to this man sitting in front of me who, may be a younger Black male with a family history of prostate cancer? His risk is probably not the same as the 70-year-old white man that enrolled in that screening trial. And so I think it's really important, and kind of goes back to something that when I was a med student and a resident was kind of drilled into my head, right? Make sure that the patient you are treating, or the data that you are quoting or using to kind of provide rationale for the treatment you're recommending, applies to that patient sitting in front of you. Do the demographics of the patients enrolled in that trial really match that person in front of you? And I would say for prostate cancer, when it comes to PSA screening, the answer is no. Treatment trials were a little bit better. Treatment trials were about 85% or so white men and about 15% non-white men. Still only about 5 to 6% Black patients enrolled in prostate cancer treatment trials. So again, kind of the minority populations are vastly underrepresented, in clinical trials. And so when we think about everything that we do, particularly in cancer care and oncology, is so heavily dependent on the results of clinical trials. There really needs to be an emphasis on making sure that those trials reflect kind of the general population that we treat. Okay, shifting to lung cancer, which is, a huge problem here in Kentucky. So this graph just talks a little bit. You can kind of see, so the two bars on the far left are in African Americans or Blacks. And what this graph depicts is simply that tobacco use alone does not account for the discrepancy we see in lung cancer incidence and mortality in Black individuals compared to white individuals, or frankly, other races as well. So you can see that tobacco use among adult men, and this is about 5 years ago, was still somewhere around 20% in African American patients. That number is as high as 30% actually in the Asian population, and somewhere around 15 to 20% in the white population. And so cancer, lung cancer rates hopefully, will continue to go down as we see less smoking. But the reality is it's not just that. So when you look at lung cancer mortality, which is the dark gray bar, you can see a huge discrepancy. Yes, more African Americans smoke than do non-Hispanic whites. But you can see that alone does not account for the discrepancy in lung cancer mortality. So African American patients are less likely to undergo guideline-recommended staging scans. So they are less likely to have a PET scan at initial diagnosis of lung cancer. So PET scans have become standard of care at initial diagnosis of lung cancer, and minority populations, and in particular African Americans, are less likely to have had what is considered standard staging scans. They are also less likely to receive immunotherapy in the advanced setting. And if you haven't realized that immunotherapy has kind of completely changed the landscape of cancer care, you probably haven't come to enough grand rounds. Immunotherapy has just really changed what we do and has really resulted in huge improvements in survival. And if you have, a group of patients who have less access to that, life-saving treatment for whatever reason, you're going to see disparities as a result of that. We all know East Asian women are significantly more likely to be diagnosed with EGFR mutated lung cancer. There's a whole different treatment pathway for EGFR mutated lung cancer, which involves tyrosine kinase inhibitors. And those treatments can be very effective and can prolong survival for those patients with advanced disease for several years. So that group of patients takes on kind of a whole different treatment paradigm. Certainly in an East Asian woman who's a non-smoker, that's high on your radar, right? However, I will say, because the sort of fork in the road, if you will, at initial diagnosis in terms of how we treat these people, mutational analysis of EGFR, looking for things like the ALK translocation, that mutational analysis is standard practice for all newly diagnosed advanced lung cancer patients across the board because the treatment differs so dramatically. However, Black and Hispanic patients and those on Medicaid still today remain less likely to be tested for those alterations. So again, it makes sense that you're going to test those most likely to have that alteration, but at the end of the day, it's important everyone be tested because there are certainly patients that are not being treated appropriately simply because of lack of testing. Okay. Talk a little bit about breast cancer. Sort of Blacks, American Indian, Alaska Natives, and Hispanic or Latina women all have higher breast cancer specific mortality as compared to white women. So again, going back a few slides, white and Black women have similar incidence of breast cancer, but mortality is much higher in non-white women. Some of this has to do with histology and disease subtypes. So Hispanic and Asian women are more likely to be diagnosed with HER2 positive disease or HER2 overexpressed disease, which we know to be a more aggressive variant. Fortunately, nowadays, at least we have targeted therapy for that. But still, we know that that is, in general, a more aggressive variant of breast cancer. Black women are actually twice as likely as white women to have triple negative disease. And that's really, again, a more aggressive variant. But not only that, we don't have a targeted therapy really to target triple negative disease. And so Black women, certainly are diagnosed with more aggressive disease, which may in turn translate to worse outcomes. There is, of course, an association between hormone receptor negative breast cancer and insulin resistance, obesity, environmental pollution, all of that, which seem to be higher prevalence in the non-white population may contribute to disparities. And then I think one thing to really point out is Black women have higher rates of what we would call a variant of unknown significance on genetic testing. So, we'll send off genetic testing, particularly in young women, but increasingly in a number of cancer patients with family histories to look for germline mutations that may make that person or that individual more susceptible to breast cancer. And in turn, perhaps make their family members more susceptible as well. The problem is that sometimes when we send off these tests, we get these kind of what's called a variant of unknown significance, an alteration that we're just not sure if that poses any additional risk, but is not technically a sort of normal sequence. Those variants happen more commonly in non-white populations simply because of the lack of comparison. So there's nothing more frustrating than getting a variant of unknown significance in a gene that is known to be involved with cancer risk, because you don't know. This mutation is here, but I'm not sure it really has there's any significance to it. And so how you counsel patients on that and how you counsel family members, it becomes kind of very difficult simply because we have a lack of information. At the end of the day, as more information becomes available from patients, ultimately about 90% of variants of unknown significance are deemed to be not significant, that they are just sort of normal variants. About 10% are ultimately deemed to be pathogenic. But again, if you don't have enough women or men, for that matter, being tested who are like you, when these variants of unknown significance come up that may actually be more prevalent in certain races or ethnicities, it's hard to know what to make of them until more information is gathered. And so it's really important, I think, that we continue to offer genetic testing and genomic testing of tumors to minority populations so that we can gather this information to better inform ourselves and allow us to better inform patients about how to make treatment decisions. Colorectal cancer. So Black patients, again, have the highest mortality rate from colorectal cancer. There's probably, again, multiple reasons for this. There's two I want to highlight. So one is screening. Non-white patients are less likely to undergo screening. So the table that you see there is relative risk of receiving screening by race and ethnicity, so basically white and non-white. And you can see that for every income level, non-white patients are less likely to undergo colonoscopy screening for colon cancer, and which we know can certainly lead to removal of polyps prior to becoming a cancer or earlier diagnoses that put patients in a much better position as far as being the likelihood of being cured. So first of all, screening, again, coming down to access of care and stressing the importance of that. Although they're less likely to undergo screening, interestingly, the disparities persist even when you match for stage and you try to standardize the treatment as much as possible. So there was a study, a National Cancer Institute cooperative study for stage 3 colorectal cancer, where patients were looking at adjuvant chemotherapy. So this was a very, I guess, as homogeneous of a population as you can get, in the sense that all the patients had stage 3 cancer. All were receiving very standard protocol-directed treatment. And yet, even in that study, Black patients, particularly those under the age of 50, had shorter disease-free survival than their white and Asian counterparts. And so it's not just the treatment they receive, it's not just kind of being diagnosed at a later stage, but even stage for stage, there were worse outcomes in Black patients as compared to other races and ethnicities. Secondly, the benefit of biologic agents. So in colorectal cancer in the advanced stage, we have FOLFOX and FOLFIRI, which is, of course, kind of, standard 5-FU-based cytotoxic chemotherapy, but targeted agents and biologic agents that target VEGF or EGFR. The benefit of those agents in the treatment of metastatic colorectal cancer in minorities is really unclear. So just like we talked about in prostate cancer, minorities are grossly underrepresented in colorectal cancer studies, particularly in the metastatic setting. What that means is the results we know we can hopefully extrapolate to patients that look like the patients enrolled in that clinical trial. But what about when you separate out other races or ethnicities? There are folks that have tried to do that, and to be honest, probably in part because of small numbers, which really kind of underpower their ability to look for significant correlations. They were unable to find a statistically significant benefit for the use of biologic agents in the treatment of metastatic colon cancer in minorities. Again, probably in large part because of lack of power to be able to identify small differences in survival. But at the end of the day, these are agents we use routinely in metastatic colon cancer. And to sort of think about the fact that there may be a certain patient population being exposed to these agents without benefit is certainly something that you kind of gives you pause. Gastric cancer. So actually, Korean Americans have the highest incidence of gastric cancer. All non-white populations are more likely to be diagnosed with and die from gastric cancer as compared to white patients. Disparity probably in part related to histology. So we know that diffuse type gastric carcinoma is a more aggressive variant associated with poor survival. And this type of histology is more common in minorities. We think associations with H. pylori, kind of poor socioeconomic status, certainly all play a role. It is actually, though, contrary to breast cancer, one of the few cancers where the majority of genomic studies and resources that are available for research, and then subsequent disease classification formulated from that research, is actually predominantly in the non-white population. So it's actually one of those situations where most of the data I have about how certain types of gastric cancer should respond to certain types of treatment is actually in the non-white population, simply because it has a higher incidence in the non-white population. So this is one of those cancers where, on one hand, it is somewhat encouraging to know that we're kind of accumulating the evidence we need to hopefully treat these patients better, but yet the disparities still exist. Leukemia or hematologic malignancies in general. So the incidence of AML, CLL, and CML are all highest in whites. However, Black patients have the lowest survival rates. So you're seeing kind of a trend here. Interestingly, the incidence of ALL is highest in Hispanics and Latinos, and this is actually true both in children and adults. There are a number of genetic reasons this is sort of postulated to be. There's an increased frequency of kind of a Philadelphia chromosome-like subtype. There's a loss of function alterations in NUDT15, which leads to an increased toxicity of treatment, which makes treatment that much more difficult to get through. And then germline variants, which may actually increase the risk of ALL. However, the incidence of ALL is steadily increasing, suggesting there is probably an environmental component to all of this as well. But again, disparities exist not only in solid tumors, but in hematologic malignancies as well, and for many of the same reasons, not only genetic, but again, kind of getting back to access of care. And if patients can't get to treatment in sort of regular follow-up and monitoring for toxicities, particularly in things like hematologic malignancy, the risk of complications, infectious complications, and even lethal complications is much higher. So in the last 15 minutes or so, I just want to talk about kind of challenges in addressing some of these disparities and some of the things that, nationally are being done to try to do this. I think that there has been a well-needed sort of reckoning, if you will, with some of the disparities and institutional racism and honestly unconsciously stacking the deck against minorities that still happens in the United States today. And I think it's important that that conversation continues to take place. And so fortunately, there's a lot of research going on into how to better do this. But, some of the challenges that have been identified, first of all, is all of the information I just talked to you about today, all of that data comes primarily from self-reporting. And in many cases, actually provider assessment of race and ethnicity. So a lot of the SEER data, for example, where we talk about large databases of cancer diagnoses and treatment outcomes is abstracted from patients' charts, right? And so how is race and ethnicity abstracted from a chart? It could be self-reported, in a patient's demographics, but it could also be from a provider note that says this African-American female. So all of this outcome data that we've talked about is based on either the patient identifying as a certain race or ethnicity, or in some cases, the provider, which is probably less accurate, right? And so there's a lot of challenges, I think, first in identifying which patients we're talking about. Access to multidisciplinary care is still often limited to very select cancer centers, usually in bigger cities, usually very large cancer centers. And when I say access to multidisciplinary care, I don't just mean the physicians, right? So multidisciplinary care is the hallmark of cancer care nowadays, right? You have kind of your surgical input, your radiation oncology input, and your medical oncology input, and we all work together as a team to kind of come up with the best treatment strategy. But I don't mean just that. I mean multidisciplinary care. I can't do what I do without social work and without, fabulous dietitians, all of that. And those kinds of, important members of our team are imperative in addressing some of those barriers to care that we talked about. Transportation, diet, getting adequate nutrition. Those are things that I can't necessarily address in a 5-minute visit. And in fact, in order for that patient to even have that 15 minutes with me to sort of address that, they have to get to clinic, right? And so if I'm in a small rural cancer center and it's just me and a couple of nurses and a couple of medical assistants, there's no one to kind of make sure that that patient got to their treatment, who's checking in on them, who's arranging their TARC, to make sure that they get there. I mean, I think that multidisciplinary care means more than just the physicians. It's actually more important, kind of everyone else around us that helps that patient kind of get the care that they need. And then again, and we talked a little bit about it, and I'm going to expand a little bit on this, but clinical trial recruitment of minority populations remains suboptimal. So this kind of drives that home. So Black Americans account for 22% of myeloma cases annually in the United States. They make up 4.5% of clinical trial participants. So this was kind of a list on the left of seminal clinical trials in multiple myeloma over the past several years, and then the percent of Black subjects in those trials. And you can see not a single trial gets to or exceeds the 22% proportion that African-American patients make up in the United States in general. The best was about 20%, but you can see there are some studies that are, 1% or less. And so there's huge discrepancy between the makeup in terms of race and ethnicity of cancer cases in the U.S. and the race and ethnicity makeup of clinical trials that happen. So again, 5% or so, about 4 to 5%. So actually those multiple myeloma numbers hold pretty true to oncology trials in general. About 4 to 5% of oncology clinical trial participants are Black, although 13% of the U.S. population is Black. We looked at our numbers here at the Cancer Center, so at the Brown Cancer Center, averaged over the past several years, 8 or 9 years or so. Black patients make up 9.5% of patients enrolled in a clinical trial here, and that holds true whether it's a therapeutic trial, so testing an agent against their cancer, or a biorepository study where they sign up to basically give blood or urine or tissue specimens for further cancer research. And in particular, those types of research studies don't involve any direct benefit to them. 8% of Kentucky is Black based on the most recent U.S. Census data. So on one hand, I was happy to see that our numbers were a little bit better than the national average and certainly at least match the makeup of Kentucky. At the same time, we have a long way to go. Jefferson County is actually about 22% Black, and a big part of our draw of our patients comes from Jefferson County. We are a community cancer center. However, a large part also comes from outside Jefferson County to the more rural areas of Kentucky as well as Indiana. So our patient mix is we have about 14% Black patients at the Cancer Center. So again, although our clinical trial enrollment of minorities is better than the national average, it still does not reflect our patient demographics here at the Cancer Center. So I think we still have some way to go. Other disparities, so there was at least one, again, National Cancer Institute cooperative group study that demonstrated Black patients are twice as likely to be lost to follow-up as white patients after their treatment on study ends. And that's important because we lose that data, right? They went through all the treatment, kind of went through all the study procedures, but then we kind of lose them to follow-up, which means we don't sort of get all that long-term survival, long-term side effect data that's so necessary to kind of inform our decisions about treatment. Again, most oncology trials are a mix of research-related procedures intertwined with routine care. So when we think about a clinical trial in cancer care, it's not necessarily just, you can do standard treatment or this research study, and the research study is all research and paid for. The reality is even clinical trials are a mix of kind of the standard routine care that a patient would typically receive, as well as, research-specific procedures. So again, requires the use of insurance benefits to come in and get that routine care, to come back for, lab monitoring, and then to come back for long-term follow-up. So again, if you have patient populations who have less access to insurance and travel becomes more difficult, again, that makes maybe their willingness to participate in clinical trials and their ability to continue to be followed on a clinical trial less than other patients. And then finally, what I found really interesting and came across is something I had not thought about before is patients' perception of clinical trial consent. So there's a lot of literature and talk about mistrust in the healthcare system by minorities, right? And there's a lot of rationale for that, and there's a lot of good reason for that. As our healthcare system has not been fair to minority patients over the years. I've never thought about it in the sense of a clinical trial consent form. So, these clinical trial consent forms, if you've looked at them, are, 20 to 30 pages long for oncology trials. And we like to think that the purpose of this consent form is to inform the subject, to let them know every possible thing that is going to happen to them on the study in terms of the procedures, what are all the risks, etc. Non-white patients are more likely to see that consent form as protecting the doctor rather than protecting them. They are more likely to see that as, oh, they want me to sign this and participate just so it kind of covers them if any of these bad things happen to me, rather than seeing that form as a way of informing them of all of the things that could happen and making sure that they're making an informed decision. So they kind of see this clinical trial consent form as, I don't want to sign that. That's sort of protecting you, not me, which I really thought was, interesting coming from somebody who, kind of informed consent and things like that is near and dear to my heart, being with clinical research being so important to me. So some initiatives that are happening currently to increase minority enrollment in clinical trials. One thing is considering racial and ethnic diversity when designing eligibility criteria. So, eligibility criteria for most clinical trials is pretty tight, right? But what a normal creatinine clearance is for a white patient may be different than a normal creatinine clearance for a black patient. And so we may be unconsciously excluding minority patients because we are designing our eligibility criteria around white patients. And so I think being more mindful of kind of normal parameters or comorbidities, excluding patients with comorbidities if certain races or ethnic groups are more likely to have certain comorbidities, are we unnecessarily excluding certain populations without intending to do so? Some people have gone as far as to suggest that the FDA should set a bar for minority participation based on the incidence of cancer in that population when considering new drug applications. So should we require, if there is a cancer, that is more prevalent and has a higher mortality in certain races or ethnic groups, should we have a minimum number of that type of patient that has to enroll in a clinical trial for those results to even be considered by the FDA? I think it's a good question. State laws, Kentucky has one requiring insurers to cover routine costs of participation. Historically, federally, Medicaid has not been required to do so. So having state laws in place that protect patients, that allow them to participate in clinical trials with at least the confidence that their routine costs will be covered. Things like outreach, so kind of going to patients where they are in their communities to try to talk a little bit about cancer care and clinical trials and why those are so important. Patient navigation models. So UAB, for example, started a program where they hired two, I think they called them health advocates to help enroll minorities in clinical trials. And so they kind of pre-screened every non-white patient that came into the cancer center for eligibility in clinical trials, sort of approached the patient about clinical trials before they even saw the doctor, made sure the doctor was aware that that trial was available and kind of discussed that with the patient, and then followed up with the patient thereafter. And just by doing that, they increased their minority population enrollment in clinical trials from about 9% to 16%. So, again, kind of really, really trying to focus recruitment efforts on patients that are historically left out of clinical trials. And then again, introducing trials early on as a part of a treatment discussion, not after the fact, not talking about treatment and then, we have this trial you could do too. But, NCCN, which is kind of the oncology professional guidance or standard practice guidelines, almost uniformly at the very top of the list is clinical trial participation is preferred. So no matter what the stage, no matter what the cancer type, if there is a clinical trial for which that patient is eligible, that is always the preferred treatment. So thinking about trials not as a separate entity, but rather as a treatment option, and introducing that early on as a treatment option, I think is certainly important. Just yesterday, as I was sort of finishing these slides and kind of preparing my talk, I saw a patient of mine who is young, so has a birthday that's 6 days different from me, so very young. Young African-American gentleman with head and neck cancer who participated in a phase 1 trial that we were doing. And, I remember talking with him about it, and, he asked some really great questions and ultimately decided to proceed with very little hesitation. And so I asked him yesterday, I happened to see him just for kind of routine follow-up, kind of what things went through his head and what ultimately made him decide to participate in the trial. And he basically said to me, because he felt that because we took enough time to talk with him about it, that it was something important that he should consider. And after he thought about it, he felt like, well, gosh, if this can help me, great. And if it can help other people like me, even better. And I thought, wow, it didn't, when I talked to him and approached him about the study, I didn't have that in mind. We just talked about it again as a treatment option. But to hear him kind of say and think through as a young African-American male what made him to decide to participate was really enlightening. And I think that that's important. One thing I learned from the webinar I mentioned earlier, where we had a patient panel of minority patients, particularly Black African American patients who had been on trials here at the Brown Cancer Center, listening to them talk a little bit, it was very eye-opening to hear people say, one of the things that I faced is I wanted to participate, but I had family members telling me, no, don't do that experimental stuff, or, for those with strong faiths, perhaps, you don't need to do that. God will take care of you. And really some of the things that they had to sort of reckon with internally were not so much their hesitation in participating, but rather their family and friends not supporting their decision to participate. So I think just, starting the conversation is really, really important. And so this is kind of the last slide, and again, I'm actually really happy. Today is the first day of fall. Being from Wisconsin, I love this weather. But, helping one person might not change the world, but it could change the world for one person. And so, my kind of way of looking at this, what are we doing at the Cancer Center to try to increase minority enrollment? I take it one person at a time, right? So I am not single-handedly going to increase the national enrollment of minority, in oncology clinical trials, but I certainly can do that in my own patient population, to talk to patients, like I said, to introduce that concept early, and to talk a little bit about barriers to care and what we can do to improve that. So I think just the conversation is important. I think continuing the conversation about disparities in cancer care and in medicine in general is important. And I think recognizing them, something we can do today is at least recognizing that those disparities exist. And in the back of our head, think about that as we're talking with patients about cancer screening or cancer treatment options, or even non-cancer care to those patients sitting in front of you later today. So that's it. Thank you all for calling in, and I'm happy to take any questions.
Well, thank you, Dr. Redman. That was outstanding. Very, very timely. So, so let everybody know if you have a question, you can you can post it in the chat area, or if you want to unmute your microphone and ask it, that would be fine as well. Had a couple of comments a little bit back, one actually from Dr. Kruger. She had one a moment ago. Said one nutrition solution might be to increase awareness of vitamin D deficiency for both whites and non-whites, however more prevalent in non-whites. The all-cause mortality is higher with vitamin D deficiency in the Cochrane database studies.
Yeah, no, I agree. Vitamin D is a hot topic, and I feel a little bit like, depending on the year, the pendulum swings back and forth. I think that there's certainly an association. The question is, I think the real question is, does repleting vitamin D or giving someone particularly high doses of vitamin D, does that actually change outcomes? Does that actually reverse that discrepancy that we see? And I think that that's still to be determined, but I agree. I think just nutrition and talking with folks about just getting at least kind of the recommended daily allowances of various vitamins and minerals is important.
And another comment, this is from Dr. Krishnasamy, said, thank you, Dr. Redman. It appears that the health disparities we see in access to diabetes treatment and also complications and outcomes mirror what in the oncology area, and said the message that you so elegantly summarized.
No, thanks. Yeah, I think it's not unique to oncology, and that's part of why I kind of chose this topic for Grand Rounds too. This is not unique to oncology, and in fact, I remember when I was a med student talking about treating hypertension differently in Black individuals than in white individuals with different classes of antihypertensive. So this is not unique. I actually feel like perhaps, oncology, despite our, like I said, our kind of boutique medicine approach where we like to personalize care, we might be behind, general medicine in the sense of kind of recognizing these disparities and really digging into why those exist.
Yeah, and Laura Bishop, she did ask, how do we begin to overcome legitimate concerns that our non-white communities have with enrolling in clinical trials, but then said that you answered her question. Another comment from Dr. Kruger, culture is the way you see the world and your perception of the way the world sees you. It will be complex and require a lot of insight and work, and most likely having non-white faculty who most understand non-white culture to reduce these disparities.
100%. And so what's really interesting, What's really interesting about that is I will say, part of this webinar, like I said, that I was fortunate to be a part of last year about racism and clinical trials and cancer in general. We invited Eric Burton, who some of you may remember was a neuro-oncologist here at the Cancer Center and is now at the National Cancer Institute, to speak. And he's an African-American gentleman, and he talked about how early on in his career he had mentors, kind of who were also African-American, and told him how important his role was as an African-American physician to be able to advocate for things like this. But at the same time that he had to be mindful because, all of us recognize how important it is to have that input, to have a faculty that is diverse. But that sometimes we can inadvertently put a little bit too much on them as faculty to kind of talk and speak and be the one to advocate. So it's kind of interesting to hear him talk and how he professionally balances that, to be honest. But I think you're 100% right. I think having a diverse faculty who understands all of those backgrounds, or at least, comes at it from a different perspective is so important.
A question from one of our community doctors, Dr. Philip May. How does obesity increase risk for cancer?
Yeah, that's a great question. So there's probably a lot to that. Some of it has to do with insulin resistance. Some of it has to do, honestly, with the tumor microenvironment and the immune response. So obesity and some of the inflammatory markers that are upregulated in cancer as a result actually counterintuitively decrease the immune response. And so some of that is felt to be related to a decreased immune surveillance. So not only increase the cancer incidence risk, so the increased likelihood of developing cancer, but also a decreased response to treatment, in particular, maybe even immunotherapy, because of the tumor microenvironment. But it's not totally understood, to be honest. I think there's a lot of reasons that are postulated.
Another comment from Dr. Bishop said, "This was amazing. Thank you for reminding us of the impact we can have with our individual patients. It can feel overwhelming, so remembering that we do have some power within our practice to create change is important."
Yeah, I think that's so well said. That's awesome. We all have, every patient we see, we have the power to change.
We have a question from Dr. Stanley Levinson. He's a researcher. How does the social/economic status feed into these disparities?
So it does not go unnoticed that minorities are socioeconomically disadvantaged in the United States. And so while they're not parallel, right, it's not that all of the disparities we see are related to kind of a worse socioeconomic status. There's certainly an interplay there, and it's impossible, and I think would be naive to talk about disparities in care for minority populations without addressing the fact that the reality is minority populations, again, are less likely to be insured. They generally are more likely to live in poorer neighborhoods and have less access to, what we would consider quality medical care. So it certainly plays a role, and I think it would be, neglect to not talk about that, although it's not all of it. There's certainly more to it.
All right, real quick for everyone, if you can take a look in the chat area, Jess Petrie just posted a link from a JAMA article about the systemic review on association of obesity with survival outcomes in patients with cancer. That's from earlier this year. So there's a link there if it's anyone that wants to take a quick look. It's in the chat area right now. One last one, Dr. Aaron Murphy says, "Thank you so much, Dr. Redman. A wonderful talk. I will change my prostate cancer screening SDM as a result of this."
No. Well, I mean, I think it's just all about kind of empowering our patients by kind of, again, just sort of filling ourselves with as much information as we can about how this impacts our daily practice. So thank you all for listening.